Hey everybody, this is Kevin Bass from the.wars.com, and I want to go over statins, risks, benefits, and myths about statin therapy. I'm motivated to do this by the fact that we often hear a lot about statins being, a terrible drug, it's very bad for you, etc. But if you actually look at the data, the evidence, you will come to the opposite conclusion. Statins are one of the best longevity drugs, if not the best longevity drug that we have. Long before we ever had this discussion about what sort of agents or supplements will enhance lifespan or health span, statins were out there doing just that. They're highly effective, and it's a little bit troublesome and disturbing that they're maligned, despite the fact that they are such, in many ways, like wonder drugs. So one of the first things I want to mention, though, is that statins are generic. So statins are not on a patent. Big Pharma is not making a bunch of money from them. Big Pharma can't. They can be produced anywhere in the world, in a random manufacturing plants in India and Bangladesh and China for pennies on the dollar, and that's why they're so inexpensive to buy as generics now, because they're not under patent and Big Pharma can't make a bunch of money from them. In fact, if anything, Big Pharma has been trying to show that they are not good. So Big Pharma has an incentive to show that statins are terrible, because then they can sell the newer generation of LDL lowering medications that they can then cause them to make a lot of money. So if anything, pharma actually is incentivized to downplay and to marginalize the efficacy of statins in order to sell other medications. So it's not the reason we hear good things about statins is not because pharma is telling us it's because the science is telling us that statins are a wonder drug. To that end, I take a statin. I take also ezetimibe, which blocks cholesterol reuptake in my gastrointestinal tract and prevents me from, basically you secrete some cholesterol into your GI tract, and then you recycle it by taking it back up, and then it goes back into your bloodstream again. If you block that process, you lower your blood cholesterol levels. And then in addition, I also take a statin, which blocks synthesis of cholesterol in my liver cells and causes the liver to then take up the cholesterol and lower my blood cholesterol level. And I walk around with a LDL cholesterol level of about 50. That's much lower than what it used to be, which is about 100. And I think it's great. I'm going to keep doing this for the rest of my life. I'm a believer, and I'm not saying this in order to say, okay, my anecdote is the truth. It's not. Because it's not. My anecdote is not the truth. My anecdote is meaningless. But it's I put my money where my mouth is. So in this case, I take a statin because I think it's a highly effective longevity intervention, and if I take it my entire life, I think I'm going to yield great benefit from doing so, and I'm excited about that. But I'm going to talk to you guys about the risks and benefits of statin therapy in an objective manner using this excellent article called The Interpretation of the Evidence, the Efficacy and Safety of Statin Therapy, and it's by many of the luminaries of the field of cardiovascular disease research. And it goes systematically over the risks and the benefits, including, as people like to talk about, memory, muscle pain, diabetes, etc. Many of the things that are often said to be a side effect of statin therapy, this review touches on. And I'm going to go over this review briskly because I don't think people are going to be interested in hearing me meander and talk at great length on the various details. I'm going to just give you guys the overview of what the review says. Before I do that, I do want to point out what this review is actually trying to do, and I'm going to do that by reading the first few sentences of the summary. This review is intended to help clinicians, patients, and the public make informed decisions about statin therapy for the prevention of heart attacks and strokes. It explains how the evidence that is available from randomized controlled trials yields reliable information about both the efficacy and safety of statin therapy. In addition, it discusses how claims that statins commonly cause adverse effects reflect a failure to recognize limitations of other sources of evidence about the effects of treatment. Large-scale evidence from randomized controlled trials shows that statin therapy reduces the risk of major cardiovascular events by about 1/4 for each millimolar reduction in LDL cholesterol during each year that it continues to be taken. So good benefits and the risks are overblown. We'll explain why that's the case as far as the latter is concerned. Why is the risks overblown? Let's first start out with what can we expect from statin therapy as far as the benefits. So lowering LDL cholesterol by 77 milligrams per deciliter with an effective statin regimen for 5 years would typically prevent major vascular events from occurring in 1 in 10 with people with pre-existing disease. So 10% of people over the course of 5 years would see a prevention of their major cardiovascular event. And 1 in 20 among people who are at increased risk but have not gotten an event so far. These benefits increase over time. The same treatment, so we're talking 5 to 10% benefit of a major vascular event being prevented, the same treatment would cause myopathy in 1 in 2,000. So that's, it's about 200. So the number of people who would be benefiting as far as a major vascular event are about 200 times larger than the people who are getting myopathy. So for every 200 people who get a major vascular event prevented, about 1 person gets myopathy. This is what that statistic is saying. Diabetes, 1 in 100 to 1 in 200 again. So it's about 5 times more, 5 to 10 times more people, or 5 to 40 times more people benefit from statins versus people who are getting diabetes. This benefit meaning they're preventing like a heart attack versus people who are getting diabetes. Hemorrhagic stroke, 1 in 1,000, 1 in 2,000. Again, it's about a 100-fold increase, 100-fold improvement in terms of the major vascular events versus every 1 hemorrhagic stroke. So every 200 heart attacks, you get 1 hemorrhagic stroke. That's a little bit of an oversimplification. We have to add other things too. Maybe like strokes, other strokes, etc. But yeah, it's like the benefit is overwhelming compared to the increase in risk of these other outcomes. Statin therapy produces large benefits for cardiovascular disease, but there is no good evidence that it has benefits for other outcomes. With that said, we'll talk a little bit about cognition, and in another video we'll talk about erectile dysfunction because I think that's a really interesting part of the story as well. Statin therapy overall reduces risk of death from all causes, as you can see in this figure, and the reason is that it doesn't increase risk of death from other causes. So it only really hits coronary artery disease, and it reduces the risk of death from coronary artery disease, but the other causes of death are not affected by statin therapy, so it doesn't increase the risk of, say, cancer or something like that. So overall, you're going to get a massive reduction in risk of death from statin therapy, all-cause mortality. Reduction in cardiovascular events from statins is related in a dose-response manner to the reduction of LDL cholesterol. So the more LDL cholesterol you reduce with statin therapy, and in my case, I've halved my LDL cholesterol from about 100 to about 50, the more you're going to get a benefit. Each decrease in LDL cholesterol produces additional benefit. Each year on statin therapy produces additional benefit. And I've just started to feel that I think I had niacin this morning, so I've also been playing around with niacin, so I might start turning red soon. If I start turning red, that's why I'm starting to feel flushed a little bit, so I might start turning bright red. If that happens, don't worry, I'm okay. Although it does burn a little bit whenever I get this flushing. But in any case, so yeah, with each reduction in LDL cholesterol, you get more benefit. And with each additional year in which you've reduced your LDL cholesterol, you get additional benefit. That's the idea. Statin therapy does not affect cancer risk in either a good or bad direction, has no effect at all. Myopathy is a proven rare risk of statin therapy and it occurs at a rate of 1 to 10,000 for each year of statin use. It usually resolves rapidly when statin therapy is stopped. Diabetes is another uncommon risk of statins at about 1 or 2 per 1,000 patients per year. However, the major complication of diabetes is cardiovascular, and statins reduce cardiovascular events even in diabetes. So this makes diabetes risk from statins of uncertain clinical importance. There may be an increased risk of hemorrhagic stroke, but decreased risk of ischemic stroke. Overall, the increased risk of hemorrhagic stroke is overwhelmed by a much more massive overall cardiovascular disease benefit. It's a trade-off, and the trade-off is in favor of the benefit. Overall, statin intolerance is rare, and similar rates of intolerance are found in the placebo and statin arms of clinical trials with statins. This suggests that most reports of statin intolerance are due to nocebo or other effects, not due to the statins themselves. Randomized controlled trials failed to find any difference in myalgia between statin and placebo-treated groups, suggesting that muscle pain from statins is not due to the statins themselves, but other factors such as nocebo. The STOMP trial looked at muscle-related outcomes such as strength, endurance, sports performance, and physical activity, and saw no difference between the statin-treated and placebo groups. One moment, I just actually want to go point out another thing. So this actually leads to another paper that was published last year. It was published in Nature Neuroscience. Nature Reviews Cardiology. 60 patients, they reported statin pain. They're given 4 bottles each of statin, placebo, or no pills, randomly given each bottle each month for 12 months. And they were asked to report their muscle pain on a scale of 1 to 100. The average reported pain on the empty bottles was 8. It was an 8. They gave an 8. The average reported pain on placebo bottles was 15.4. The average reported pain on statins was 16.3. Meaning for most statin pain, so if you compare the pain on statins versus the pain on an empty bottle, and you compare the placebo compared to an empty bottle, and you look at the difference, so if 15.4 is the rating on placebo and 16.3 is the rating on statin and 8 is the rating on an empty bottle, that shows that placebo accounts for the large majority of statin pain. Maybe there's some small effect of statins themselves in addition to placebo, but it's not big. It's a really small effect. So that's important to point out. And that was based on a paper called The Neuropsychology of Statin Intolerance by Jennifer Robinson. And she writes, statin nocebo effects have been demonstrated in numerous randomized double-blind, placebo-controlled, and active-controlled trials. Emerging evidence suggests that brain pathways might mediate statin nocebo hyperalgesia. Evidence-based pain management approaches can be used to manage nocebo symptoms that occur during statin therapy. Most of the muscle pain during statin therapy is from nocebo. It's not from the statins. Okay. All right, let's continue. A meta-analysis of 26 trials over 100,000 patients showed little difference in muscle pain after 3 years of treatment. Statistically, about 1 in 1,000 patients, although the result was not statistically significant. And we can actually go look at this famous Feingold paper called What Proportion of Symptomatic Side Effects in Patients Taking Statins Are Genuinely Caused by the Drug? Systematic Review of Randomized Placebo-Controlled Trials to Aid Individual Patient Choice. This is a Feingold, Ben Goldacre, Darrell Francis. I'm sure these other people are notable. I'm not a cardiovascular researcher, so I don't know who everybody this is, but there's some interesting names on this paper. And they write, they have this really cool table that I enjoy a lot, where they show that muscle aches and myopathy symptoms, the rate at which they happen, it's no different. So myopathy symptoms happen in about 0.1% in the statin group and then 0.1% in the placebo group, okay? So there's no statistical difference, and muscle aches happen at a rate of about 7.9% in the statin group and then 7.6% in the placebo group. Again, no statistical difference. Now, is there a small difference in the statin pain between the statin and nocebo groups? Yeah, there's like a small difference. It's not statistically significant, but maybe some of it's real. Yeah, maybe some of it's real, probably. there's probably a low incidence of muscle pain, but the vast majority of it is related to placebo or nocebo. So, or it's just normal muscle pain that's misattributed to the statin. That's what the randomized controlled trials show overwhelmingly. So if you have muscle pain on a statin, it doesn't mean that you're getting it from the statin. It might just be life events, or it might just be in your own head. And you think you're getting it from the statin, but you're not. I can tell you guys a story. This is a little bit personal, but whenever I was young, like my parents ignored me a lot, and it was kind of like a hard upbringing. But one of the things that happened when I was a teenager, I think I was maybe 14 years old. Maybe part of me was like so tired of being ignored, or I don't know exactly what it was. It's rather complicated actually, and it would be its own podcast. And I think I'm starting to really turn red. My ears are starting to like flush. I feel like I'm starting to flush in front of the camera. I'm starting to turn red. It burns, you know, the niacin flushing. I'm starting to turn red in front of the camera. But whenever I was a kid, so I had these fake seizures. I literally thought I was having seizures. I was sure I was having seizures. I would I experienced it as if I was having a seizure. But then what they did to try to figure out, okay, how do we treat this issue? They gave me an EEG to wear, and I actually remember having this EEG strapped to my head, where the nodes, the electrodes were all on my head. And then I would report when I'd have a seizure, right? And then they saw no difference in the brain activity. The result, the diagnosis was that there was no seizure, dudes. It wasn't a seizure. I wasn't having any seizures. I was having what was called a pseudo-seizure. It was a conversion syndrome. Conversion syndrome is basically where basically some aspects of mental distress get converted into physical symptoms. So in extreme rare cases, you can even lose your eyesight. You can have all sorts of stuff that happens to you. Like, there's really powerful effects of this kind of conversion syndrome on physical symptoms. Hypochondriacs are kind of conversion syndrome, but for me, that was how my conversion syndrome manifested at the time. And once I found out that these are fake seizures, pseudo seizures, I was like, oh, okay, and I stopped having them. You know, I've had so many experiences like this where I fooled myself into thinking like something was happening when it wasn't, based on certain psychological factors that are not related to the actual, not related to the thing I think that they're related to. And I just share this with you because many people will see this video and be like, no, I'm sure I had these muscle pain from this. I tried it. I went off and went on again and went off and went on again. But even then, it doesn't necessarily mean this muscle pain was from the statin. It could have just been in your head. And as somebody that's happened to many times, and I remember during med school, I remember for every block, I'm turning bright red. I remember for every block, I would have like many of the diseases that we were discussing in the block. So for example, for like the cardiology block, I would start to get like chest pain and stuff. I actually had chest pain from indigestion, but I misattributed it to like, I thought I was having like a heart problem. But this is what humans do. Humans often can be hypervigilant and think that they're having symptoms when they're not really having them. And the literature on statins indicates that as far as muscle pain and myalgia are concerned, it's pretty much the case that that's what that's caused by. It's just it's a mental thing. It's not related to the statins themselves. It's related to just people believing that they're going to have these problems. All right, but let's keep going. Crossover trials among patients who repeatedly report intolerance to statins due to muscle pain show that these patients usually cannot distinguish between the impact of placebo and statins on their muscle pain, although a small percentage can. So they did this one study where they put some people on simvastatin versus placebo, and about 43% on simvastatin noticed that they had muscle pain that they didn't have placebo, but guess what? 27% had muscle pain that they didn't notice on placebo that they didn't notice on simvastatin. And these were among patients who often had muscle pain due to statins. So they were statin intolerant patients, and then you gave them placebo and simvastatin, and most of them, or at least a large proportion of them misattributed their muscle pain to the placebo rather than the statin whenever you crossed them over into the different interventions. So you gave them placebo and then simvastatin, and they thought they were having it on a placebo, showing that a large proportion of those patients are actually not having muscle pain due to the statin itself. And a similar crossover trial among 131 patients with a history of muscle complaints who are randomized to simvastatin 20 milligrams daily, then placebo, or placebo then simvastatin, muscle pain was reported by 36 of the patients while on simvastatin but not on placebo, versus 29% of them on placebo but not on simvastatin. So barely any difference at all of the people who are reporting it on placebo versus simvastatin. In any case, the above findings indicate that muscle pain greater than placebo probably exists but is rare. Among those in whom it occurs in the real world, most of it is due to nocebo and not the statin. Of the 1 in 1,000 to 1 in 500 patients who experience muscle pain in excess of placebo, only about 5 to 10% of those cases require stopping the statin due to risk of rhabdomyolysis. Memory loss is an off-cited side effect of statin therapy and is reported in observational studies, but no effect is found in randomized controlled trials. Among about 5,804 patients aged 70 to 84 randomized to a statin or placebo, a battery of psychometric tests showed no difference in cognitive function at 3.5 years. So no impact on cognition. A larger study of more than 20,000 patients randomized to statin therapy or placebo showed no difference in the development of cognitive impairment or dementia over the course of 5 years. A subgroup analysis of patients aged 75 to 85 showed the same result. The same finding was reported in another trial. 2 trials in Alzheimer's patients indicated a possible modest potential benefit for statin therapy. So not just no evidence of detriment, but actually even a potential benefit, consistent with the fact that cerebral vascular disease in the brain's blood vessels, contributes to dementia, and statins improve cerebral vascular disease. So actually there might be a benefit to cognition. Strong evidence shows that statin therapy does not cause an increased risk of cognitive impairment or memory loss or dementia in randomized controlled trials, and may do the opposite. A decline in reported quality of life is not associated with statin therapy in clinical trials that looked at this outcome. CRISP trial evaluated quality of life specifically. It found no difference in physical function, sleep, social support, depression, cognitive function, or health perception at 6 and 12 months among 431 patients randomized to statins or placebo. Statins have been associated with an increased risk of cataracts from observational studies, but observational studies are biased, and randomized controlled trials have indicated no effect or a very small one. Statins probably slow the progression of kidney disease in randomized controlled trials, but uncertain clinical benefit. Statins may be associated with other effects like liver disease, sleep disturbance, aggression, suicidal behavior, erectile dysfunction, neuropathy, but these are almost certainly small and will not alter the current risk-benefit ratio from statins even in low-risk patients. Statins are associated with overwhelming benefit, yet modest or rare side effects, making the risk-to-benefit calculation clear in favor of statins in most patients at risk for cardiovascular disease. Among 1 million patients taking statins, about 20,000 would avoid major vascular complications for each year that the statins are continued. 20,000. But statins are off patent and cheap. And so a lot of these reports on statins intolerance are actually funded by the pharmaceutical industry to cause people to not want to take statins and to take these other LDL lowering medications. So again, Big Pharma wants you not to take statins. Big Pharma doesn't want you to take statins. Big Pharma wants you not to take statins. I'm here not at Big Pharma. Nobody's paying me for this. Some Patreon followers, some people who do consultations, etc., are paying me because they want to get the real evidence, the real truth. But yeah, it's all right. Anyway, let's keep going. Statin therapy is massively underused among patients with pre-existing cardiovascular disease, even in countries with advanced economies and ready access. Negative media attention about statins causes people to discontinue their statin therapy and likely results in thousands of excess major vascular events around the world. All right, and then I get thirsty and I beg for some donation. So yeah, by the way, if you did like this, please donate if you like this or my work in general. And you can do that at thedietwars.com/support-me, or you can do that at my Patreon at Kevin and Bass, KVINNBASS, or you can even sign up to the highest tier and talk to me once a month about some of the topics that I discuss on this podcast. Alternatively, you can even sign up for consultations and we can do something more intensive where we really dive into your issues, and that's a little bit more expensive than the top tier on Patreon, but send me a message. You can do that on my website on the consultations tab. So here's a really interesting one. The recent Samson trial showed that 90% of muscle symptoms in statins are also elicited by placebo. So only about 10% of the time when you have muscle symptoms on statins, only about 10% of the time is that real. Most of the other time it's elicited by placebo or it's some other thing in life. It's a nocebo effect. It's like whenever I thought I was having seizures. It's a similar thing. So that's why I take a statin. I do freaking Brazilian Jiu-Jitsu. I do wrestling. I train MMA. I love wrestling. I love MMA. If I wasn't going into science and being a doctor, I would do like real MMA. Like I would like compete and punch people in the head. But of course, since I need to maintain my cognitive and brain function, most of the MMA I train is very light as far as striking is concerned. I don't train like hard striking to the head because it's not healthy. So like I tap. I tap to the head. We do taps to the head, and people respect that at my gym. Everybody at my gym's really cool. But I go hard, I train that. I gain muscle at the gym. I go lift, all that stuff, and I don't have any problems with this stuff. And if I did, I would probably think it's a placebo effect, and I would probably want to get some other tests, et cetera, et cetera. So if your doctor dismisses you for having a myopathy or myalgia, hey man, like maybe it's placebo. It would be nice if we had placebo pills that we could then give people to try and see, like their doctor could also prescribe you placebo at random to test whether you're not really getting the myalgia from the statins. That would be something very interesting to have done. But I guess we're not going to, we don't have that right now. And not in mainstream practice anyway. Anyway, if you guys like this video, I hope you did. I hope you liked this video. We're gonna have some other videos coming up about statins really soon because there's some other research that I do find very interesting that can kind of modify some of our understanding of some of these things. Particularly, I want to talk about erectile dysfunction and brain function. The bad brain and the good brain. But yeah, so if you liked it though, please subscribe, share it, comment, let me know what I can do better. I'm constantly listening to you guys and paying attention to what you guys say. So if you can let me know how I can do better or let me know what I'm doing well, that would be fantastic. Please let me do that. What else? You can find me on Kevin and Bass, KVINNBASS on Instagram, TikTok, Twitter, as well as Patreon, as I mentioned earlier. You can find my podcast at The Kevin Bass Show or also on YouTube at KBass Philadelphia. Again, let me know what you think about this. Share this stuff. Let the world know about this content because I think it is some of the best. So, hope you enjoyed that. See you guys soon. Peace.